So, sir, what I wanted to ask, as we are now very health conscious, we do a regular screening of the blood metabolite test, cholesterol levels and all this. Do you think that we should also go for this kind of mental health testings with certain scales so that we can understand where we stand and we can act accordingly?
That will definitely create some amount of additional problem. But if I examine the patient and if there is any complaint from the party, I will have to assess the party and the patient both during my examination, and then I will have to come to the conclusion that he will have to go to the psychiatrist or assessment for his mental function periodically, considering he is having some amount of impairment.
Yeah, exactly. As we do for, let's say, thyroid, if we have higher TSH levels, so after certain time they are again go for testing. So yes, that's what I wanted to actually know. And the same question to Dr. Acharya, that do you think that since you already mentioned that we are at every moment vulnerable to any kind of psychotic shock and for any kind of mental disorder. So do you think that there should be some regular assessment in a regular interval that all these functions are going well or not? I think this study also knows that there are certain scales for measuring certain traits, right? When you worked for dyslexia, I worked for ADHD. So there are, like, let's say impulsivity, let's say inhibitory control. So there are certain scales that can that have the simple questions with yes, no, or some scores, and that can actually assess how you are behaving for the last 2-3 months or for the last week. And do you think, Dr. Acharya, that this kind of scales should be taken into consideration for making a better mental health awareness? And do you practice it in Calcutta or West Bengal? Because in abroad it is practiced. So do you practice there?
Yeah. Again comes. It's a very tricky question. Okay, it's very tricky in because in many senses, because when it comes to the context of Kolkata or India, screening everyone, screening the entire population for any kind of mental health issue becomes a very laborious job, okay, and next to impossible. So actually we start to douse the fire where the fire has already begun. Okay. Yes. Because there are so many trees whom to target. That is a big question. The thing is that one common criticism of using the scales has been that are they actually over medicalizing the normal stresses of our lives? Okay. Are we overdiagnosing the psychiatric illnesses? Yes. Say, for example, that is a big question. I mean, if we even keep aside the question of rating scales. Say, for example, for the last few years, we are diagnosing ADHD and autism in much more frequent manner than we used to do it previously.
But
so what has changed?
Yes. Yes.
Why so?
So what has changed actually? That is the question. It's a very controversial thing, I know. But what has changed actually is actually the prevalence or incidence of ADHD and autism in children actually rising, or there is something else?
Yeah, that's a very good
or
question.
There is some environmental.
Yeah, actually, I want to point it in the way that when a scale is used for assessing a certain symptoms, one may have a very big score in that. But of course, when it is considered for clinical perspective, It has to be considered along with the score and with the discomfort or disability or deficit of the patient. Like I make score 90 out of 100 for a cognitive deficit test. But if that does not interfere with my everyday day-to-day life, my work life, my learning processes, so that is not to be taken as a caution for me. But at the same time, there is a very big problem. I think as of now, all the scales that we use are not constructed for Indian standard, most of them.
Yeah,
even
that's a very, very pertinent
so every scale has some construct validity, reliability, construct validity, and content validity, those kind of things. And that for mental disorder, that change from one population to another. That is
even
one
even
thing.
if you take the example of very commonly used cognitive assessment scales like MoCA or Adhd, okay, they are very commonly used, but there are certain pictures, I cannot remember whether it is in MoCA or Adhd, the picture of a heart. There is a picture of a heart in any one of them. I cannot remember actually. So Indian people actually, they have not seen a heart. What is a heart?
So
what
those
the hell is that thing?
Yes, so those questions are not Indianized. It's not validated in India.
So
most of them.
That's why we need to validate. We have actually, as far as I can remember, MoCA has been validated in India using some different things, and there are certain different questions we have used. So
yes,
things need to be.
Coming to your point about ADHD and ASD, what I want to mention is that now with the advancement in research for ADHD and ASD, earlier ADHD was used to be considered as a disorder when it is extreme. Like the extreme manifestation of ADHD was considered as ADHD, but now with the kind of with the kind of gradation system, even for autism also, there are high functioning autistic traits and low functioning autistic traits. So what you see as the increase of ADHD or ASD rate, it may be in the reality it is increased because the scaling pattern or because the understanding pattern has changed with the advancement in research. So it is not like that we had probably around 2007, we had a worldwide prevalence of ADHD around 7% or something among the schoolgoers. Now it has probably shoot up to 11 or something. So this 4% rise may not be biologically rise. That means it may not be that the 4% is certainly with a new biological hit they are developing, but it may be that we are considering it in a different way so that many other children who are not considered at that time are coming under the umbrella of the disease. So, that is one point of scaling. So please, please you continue.
Yeah, that's why but however, the thing is that there are certain very simple to be administered scales like Prime MD, which can be used very easily at a clinic. But the thing is that, as we know, there are two mainly screening tools and there are diagnostic tools. Okay, so screening tools, it's not a custom in India to administer a screening tool to everyone who comes to a clinic of a physician. Okay, when it's coming to a psychiatrist, then it's a different issue because he has already developed some stresses and some relevant problems for which he has come, some distress, some disorder, whatever it may be. But even in actually the interesting thing is that in India, the psychiatric illnesses, especially depression and somatic symptom illnesses, mostly they get treated pharmacologically by the physicians, not by the psychiatrists. Okay, that is the actual scenario. And that is something that needs to be done actually, because if and everyone comes to a psychiatrist, and as we know, the psychiatrist and population ratio in India is quite disparate. So that cannot be done by a psychiatrist. Okay, so a physician, primary physician even should treat depression. Okay, but the thing is that how many primary physicians actually know very explicitly about depression and other mental illness? That is a question, because frankly, in our undergraduate course, mental health is given the least important.
Yeah.
Okay. So the way it is being treated, that okay, I am the symptoms are not fitting with any physical illness, so it must be some psychological or mental illness. So let's give something SSRIs or something else. And
until or unless it is an insanity,
okay.
so it is not a mental problem. That is also another point of the story.
Because once you go to a psychiatrist or a psychologist, you are insane. So that's a big issue. That's a big issue. And that's why if a physician attempts to screen everyone in his clinic with a tool which screens for mental illness, he is going to lose his patient.
Yes.
Because
So
the patient,
what I want to say
the
is
information
like,
will be passed.
yes, so that's a social perspective. But what I
Yeah.
wanted to mean is that it's not for everyone, but and not for the clinicians only. Can that be like, because in abroad there are certain tools. I think this study also knows that you can self-assess yourself, and if you have high scores, then you go to the doctor, go to some specialist, and then you say, and then after they examine, if find everything is fine, it's fine. So that kind of awareness, once we are aware, then only we can adopt it for our practice.
Yeah,
right?
that kind of awareness can be spread very easily. There are certain apps available in smartphones which actually incorporate certain screening tools. Say, for example, Cage Questionnaire or Prime MD, as I've already told, or GAD, GAD7. There
Those
are
are
some
validated.
apps. Those apps are Cage Questionnaire. Actually, if I am not wrong, it would not need validation, because it's very four questions, yes or no answers. But Prime MD, GAD7, many of them are
They are
validated.
validated.
Okay.
They are validated.
They are
apps.
validated.
Yes.
Okay. But the apps, they are not developed by, as far as I can remember, they are not developed by Indian software companies. So the apps which are available are actually is in the context of the Western population. So now the question is that if the questions are not much culturally variable, I mean, not varying too much culturally, and the person who
can be taken.
can use the app or can use the smartphone, he can check. But to the broader population of India, this should be a difficult thing to reach. Yeah. Now, another question arises that I am using the apps, but do I know about the validity of the app? Whether the app
That's
is
what I
actually
asked.
valid?
Yeah, that's what I asked, that whether it is validated in for that particular thing. So
But yeah, I will have to go through them. Every time if you give a search at Google that my mental health status checkup, there will be lots of questionnaires.
yeah,
Yes,
but the problem is that those are not taken seriously. Like if I score 10 out of 100, I will not take it seriously, because I have a perceived mind that it is just for fun. But what I wanted to know, can it be developed in a very serious way? Like if I have high blood sugar, I will never make a joke out of it.
So Subhamita,
It can be done, but before that, destigmatization of mental health issues are to be taken seriously before taking such a step.
yes,
Otherwise, the app will be like a video game or something. I will just like horoscope, as I know that there are certain horoscope apps. We take it frequently. How it's going to be today, it will be like the mental health apps will be like that horoscope apps.
Yeah, so basically this thing comes again to the same thing, that the awareness has to be grown. Yes,
so,
this study.
That's true, but I mean, certain things from the very important things are coming up from this discussion. Two things I just want to mention, that while working with the learning disorder, Several things I have experienced. One thing is, of course, that there was once I started working in this, there is actually lacking of any kind of the indigenized scaling, means what Dr. Acharya and you are again and again saying, that's actually very important thing. And we from NBRC has developed, throughout the course of time, the dyslexia assessment tool that purely Indianized. So for a sec, I just want to share my screen, and I just want to show you that I'm sure that will actually help. Lots of people that probably, can you see this screen?
I can see this.
This is the Dyslexia Assessment for Languages of India. It has been developed by NBRC, and I am quite fortunate that I got a chance to work with Dr. Nandini Chatterjee Singh, who has developed, who
is the pioneer of the dyslexia studies
exactly
in India.
And this has been in the 4 language of, and like here it's mentioned English, Hindi, Marathi, Kannada. So although it's for Bengali also it has been started. So like that, there are, as Dr. Acharya has mentioned, that there are certain apps, and it's not all they are just bogus. They are some important apps, they are some important Indianized tool, and they are study. But the thing is, somehow we always has a tendency to critic more rather be optimistic, and yes,
exactly.
we are doing good, and yes, we can publish, we can do a wide publicity of these tools or these apps.
So the awareness and circulation of the information, that the scale that you presented here, perhaps few of us know, perhaps Dr. Acharya knows about it. It is not only to be restricted within the clinicians or within the researchers. Parents have to know that, yes, there are this kind of scales available. So they can get that awareness. Okay, if my child is not picking up certain things during learning, so I can always consult a person who can help me to assess this one. So again, the question comes and circulates on the center of awareness. So since we have come to this dyslexia, and he has already talked about ADHD and ASD, and Dr. Vishwesh previously told about that there may be some problems since after the birth. So we know that the maternal environment, the kind of perinatal and neonatal complications, maybe the hypoxia, maybe the anxiety in the mothers during pregnancy, alcohol consumption, some kind of antibiotic, these things have got some effect, mainly in the neurodevelopmental disorders. So in India, when you check a patient, how much frequently you see that yes, the patient, the child is having this problem, and also the child has got some problem during its birth or this.
I always ask, for example, a child, usually they come, they are brought to us with a history of most commonly seizure disorder, that is epilepsy, and less commonly this sort of cognitive impairment. And in many of the cases, both coexist. And we always ask, give me exactly whether there is any history of birth asphyxia or perinatal insult. So this is very important. Two things.
Could you please explain this birth asphyxia and perinatal insult for like how a parent can understand this language?
Usually tell us that after birth, the patient develop meningitis, headache, etc. Nowadays, the parent know what is meningitis. And what the doctor say? Doctor said that he had headache and fever, and doctor said that he had meningitis, and he managed the condition. Secondly, many parents know that after birth, they report he has jaundice, neonatal jaundice. Now, these things adversely affect the developmental CNS. Because if they occur at the age of 5 years, and if they occur within 5 hours after birth, there is a gross difference, you see. And the second thing is this hypoxia. Many patients, I often ask, whether the patient cried after delivery. Have you got any idea? Or did the doctors told you that the patient did not cry after birth or delayed crying after birth? This is very, very important because the brain cells cannot withstand hypoxia less than 1 minute. So this is
lack
very
of oxygen, right, sir? Hypoxia is lack of oxygen, right?
Lack of oxygen, because birth asphyxia, the patient doesn't cry, all sorts of maneuver this way and that way. The patient doesn't cry, so he will have to be brought to this neonatal ICU and NICU, what is called, and immediately after birth, the pediatrician always try to suck any secretion in the respiratory tract. This is the first thing. If not possible, then go to NICU, and like that. And that is very important. This time is so urgent that the future will be marked by that, only that, a few minutes only. And this is very important. This is about hypoxia. And about this jaundice and other things, that is also very important, but hypoxia is first. Other things in antenatal condition, like prenatal, the mothers, what the mothers take, we must, the obstetrician should keep in mind. But the thing is this, that in the late second or the third trimester, the organogenesis, the neuronal organogenesis is more or less completed. So we must not forget to realize what the patient was taking in the early part of the pregnancy, that is within the first trimester, because the organogenesis, including the CNS development, takes place within mainly in that period.
Very important information, sir. Very important, because this is something we forget. Like when a child is born, there is some criticality, okay, that has been dealt that time, but we forget it after 12-15 years. But from that time, if there is a problem that is being carried by the child, and then we see some symptoms, and we just forget that there is this rooting cause. So thank you for addressing this topic so well, sir. So with that message, today I will conclude my program. Thank you, everyone. Be happy and be healthy always. And we are all with you. So if you have any questions, you can leave in the comment section. We will get back to you. Thank you. Bye-bye.